Hello, everyone, and welcome to Block 2 of today's Lightning Talks, where the topic is improvement of care. My name is Raha Masoodi, and I'll be your moderator for today's session. I am an undergraduate student here at the University of British Columbia studying neuroscience. I'm also a student research assistant under the supervision of Dr. Michael Kraus here with the Addictions and Court Disorders group. I'm so thrilled to be here with you all today, and I'm very keen to hear from some of our incredible speakers. Before we dive into the lightning talks, I'd like to quickly go over some housekeeping items with you all. So with respect to the format of this lightning talk session, there will be 5 talks. Each talk will be 5 minutes long, and there will be a 5-minute period for questions and answers from the audience. Given that this is a lightning talk, the speaker slides will automatically advance quite rapidly every 15 seconds. You as the audience can submit questions via Whova. There will be a Q&A tab on the right-hand side of your screen on the Whova website. So please keep your questions in the Whova Q&A function and refrain from posing any questions in the Zoom chat. Also, if there's a question you'd like to see answered that has been posted by a fellow audience member, feel free to give it an upvote to increase the likelihood of it being seen and answered. So after the lightning talk session, you as the audience can vote on your favorite talk. There will be 1 winner per block, and the winners will be announced before closing remarks. The winner will receive a certificate, free registration to a future conference, and an invitation to present at a workshop at a future conference. So without further ado, I'd like to introduce you to your first set of speakers for this session. Liz Cave and Graham McDonald from Vancouver Coastal Health will be presenting first, and their talk is titled, Building Bridges Across a Community of Care Through Virtual Substance Use Simulation. Liz, Graham, the floor is yours.
Thank you.
Thank you very much. We are Graham and Liz. Graham is a peer support worker, and I am Liz, a clinical resource nurse. With our colleagues from the Vancouver Coastal Health Regional Addictions Program, we implemented in-person and virtual substance use simulations to improve quality of care. Today, we will start by introducing our community of care, describing how we developed and implemented substance use simulations to meet its needs, and discuss our results, all at lightning speed. Our community overlays the unceded traditional lands of 14 Indigenous nations. Much of our team are uninvited guests on these lands. We recognize that prior to colonization, Indigenous people utilized sophisticated strategies to meet their needs on their land and continue to in spite of marginalization. Patients who require a higher level of care than is offered in their community sometimes have to travel more than 700 kilometers to receive care at Lionsgate Hospital. We wanted to figure out a way to deliver training to staff in remote and rural areas so people could receive care in their communities. People who live with chronic and severe mental health and substance use disorders are more likely to experience violence. As healthcare staff, we literally hold many of the keys. For better or for worse, that is also a form of power and can put us at odds with patients. So we chose to scaffold staff's learning through simulation learning, or SIMS. Our SIMs are innovated because healthcare providers are able to practice relational skills and interact with people with lived and living experience, utilizing a contrived but realistic scenario.
In our SIMs, we wanted to turn the tables so that healthcare workers were receiving feedback from peers with lived and living experience. We wanted to bring up stuff that created dialogue, level the playing field a little bit, looking at the power imbalances that may exist. The Mental Health Care Commission of Canada recognizes that involving peers and healthcare staff training is key to removing deadly stigma. In summary, in the context of the opioid overdose public health emergency, we wanted to upskill staff to multiple sites so that they were more effective, providing at least invasive therapeutic care to people who use substances.
And so we began by doing the simulations in the emergency department and seeing how that worked. And later we adapted the scenarios for film with a filmmaker and peers, and we designed these videos so that trained peer and health educator facilitators could pause the videos at key points and facilitate discussion with staff. This enabled us to facilitate learning with clinicians in person and remotely.
Family involvement in harm reduction approaches for youth with concurrent disorder. In this slide, we have caring for youth certified under the Mental Health Care Act and transferred from a rural setting. This is Walter's Day. This was a simulation that I was involved in, engagement and screening of someone who is actively using substances. Assessment and treatment planning for someone with complex care needs. Another one of our simulations. Each simulation is 1 hour long, includes a pre-brief, practice by staff, debrief, and evaluation through feedback form and survey. Through the debriefs, we have learned that tensions can sometimes be helpful. People with lived and living experience and participants enjoy the experience and found that the simulations were meaningful for them. Feasible to implement, minimal resources required with high input, high impact output, sense of safety and inclusivity was high. Replicable to other units, high interest from other sites. And the future direction, you may not be able to relate to it right now, but you do need to be able to hear it. Some of the things that are happening in the room and in the sims probably blossom outside of the simulation and the conversations that happen later, lowering barriers to their own built-in biases and expectations. No matter how much you try to be open and engaging, there's often defense, which is natural. We want to be able to do things correctly. And after the dust settles, there's a lot of looking inwardly and outwardly, and the fruits may come in the interactions down the road.
Wonderful. Thank you, Liz and Graham, for that really insightful presentation. At this time, if there's any questions from anyone in the audience for Liz and Graham, feel free to ask your questions in the Whova Q&A section. We'll have about 5 minutes of question and answer time.
That went quickly.
So we have a question from Amelia, and it says, how can people access the simulation education sessions?
It's a great question, Amelia. Through Learning Hub at learninghub.phsa.ca, people can look up substance use simulations and sign up for sign up via that site. They can also email us and we can connect people to that. Sure can. I'm just going to post the link.
We have another question from an audience member, and it says, what inspired you to create the simulation education sessions?
I think we're talking to a lot of our colleagues who were experiencing moral distress, and also just walking alongside patients as well as staff members, and just seeing how staff didn't feel like they had the tools to actually just sit down and talk to patients, and then patients saying that they felt so lonely in the emergency department, or alternatively, like that staff would react really quickly and punitively to them. And so we decided to, just based on our knowledge of relational practice, we were wondering how we could support people and support people's learning and practice of those skills, because we thought that was the key.
As a peer worker, it was a great opportunity to, for peers with lived and living experience to work with healthcare providers and share knowledge and create dialogue around that very point.
Thank you, Liz and Graham. We have another question from Carrie, and it says, would you see this resource as transferable to other settings?
Oh, definitely. And we've been in dialogue with lots of folks from other settings, but we've I believe my colleague has implemented them at other urban hospitals. We've taken them on the road to some rural sites as well, and adapted them to teach other skills. So, for instance, we worked with somebody who works in Cerner, which is our online documentation system, and so we adapted one of our simulations to teach people how to use a computer and talk to people at the same time, basically, therapeutically.
Wonderful, thank you, Liz. And if anyone has another question, I think we have time for one more. Wonderful. So with that, it doesn't seem like there's any more questions. I'd like to thank Graham and Liz for their presentation, and we would now be able to move on to the next lightning talk. It's very quick. So our next presentation is going to be by Dr. Craig Hutton, who is a data scientist with the government of British Columbia. And his talk is titled Socioeconomic Health and Academic Predictors of High School Graduation in Vancouver. So Dr. Hutton, whenever you're ready.
Okay, thank you. And okay, I see that we've got the slides up. Yep, so today, just like to thank you for inviting me and for attending the talk. And before I just get started, I'd like to acknowledge that today I'm working from the traditional and unceded territories of Lekwungen speaking peoples, including the Esquimalt and Songhees First Nations. And I'll be talking about the predictors of on-time graduation from high school in Vancouver and the downtown east side neighborhood of Vancouver. And this work is kind of promoted or supported by the Ministry of Social Development and Poverty Reduction that I work for. So that we provide primarily income and disability assistance, but we're interested in how our clients are struggling with other issues. So why do we focus on the downtown east side? Well, we've known for quite some time that it's the poorest postal code, or it's been called the poorest postal code in Canada. And here we have a map of the neighborhood median household income in Vancouver, and the downtown east side is clearly the lightest area of the densely populated areas of the city, where here light shows up as a poorer area and darker is where wealthier areas are. So they have this trend moving towards kind of point gray on an income gradient. It's also considered the epicenter of the opioid crisis. So we wanted to kind of look at this interaction between mental health and poverty. So we looked at hundreds of millions of records from multiple sources in the government's data innovation program. So this includes information on income and disability assistance through my ministry. Also from the Ministry of Health, we looked at physician billing records, vital stats, hospitalization and drug prescription records through PharmaNet, for example. Through Ministry of Education, we looked at enrollments, grades, credentials. We looked at foster care records and Statistics Canada neighborhood income. We also did this project in 2 phases. So in the first, we looked at income assistance in health, mortality, hospitalization, et cetera, in 1.7 million residents. And then phase 2, which I'm going to talk a little bit more about today, we looked at predicting on-time high school graduation. I'll provide some context for that. So in the first phase, when we were looking at health and income assistance, we found that 1 out of 5 downtown east side residents rely on income assistance, which is about 8 times higher than most parts of Vancouver. Found the mortality rate is about 2.5 times higher. Median life expectancy about 10 to 15 years shorter in the downtown east side, where the #1 cause of death was drugs or alcohol. And this kind of led us to question, okay, well, what impacts do poverty, mental illness, and substance use have on major socioeconomic outcomes, and how are they related together? And to do that, we have to kind of examine these things together in multivariable models. So we also wanted to know what was happening in youth, you know, kind of before things get bad into adulthood, which is before. So we focused in this case on individuals in grades 8 to 12, or for whom we had that data in the Ministry of Education. And we're focusing on organizing them into cohort years, where we've got on-time graduation year as being defined as 6 years from starting grade 8. So that gives people 1 extra year. And the first thing that we found in this sample was that if we look at a distribution, geographic distribution of grad rates, downtown east side appears to be the lowest again at 68% versus 83%. You've got that gradient going back up towards Point Grey, where income and graduation rate are going higher. So it seems like there's a geographic association there, which is not too surprising. And then we wanted to combine this with our information in our models. So we included information on demographic and socioeconomic predictors like age, gender, so male or female. If somebody had been in foster care, if they had children of their own, the neighborhood divorce rate was, et cetera. Information on poverty or income assistance use, their grades, standardized test scores. We also included health predictors. Information on ranging from hospitalization related to psychoses or or mood or anxiety disorders, alcohol, healthcare provider visits for opioids or prescriptions for opioids or benzodiazepines. And then we kind of applied all of these predictors, we applied models to them in 2 sets of the data. So a full sample size of 53,000, but without the grade 7 standardized test scores. And then a subset of the data where we had those standardized test scores, which was about 17,000. We found in our predictive models that the classification accuracy was better than the no information rate, or just always guessing that the student would graduate. But logistic regression we found was kind of hard to beat. The other ones were like a random forest and XG boost, decision tree based models, and a spline based model, which is the MARS. When we look at sensitivity and specificity, we found, again, I don't know why the slide isn't showing up quite clearly here, but logistic regression was again near the top, and the MARS was kind of near the top also. We found that, so sensitivity is who's predicting who's going to graduate on time, and specificity is who will not graduate on time. We found that if we adjust the threshold for classification from the default of 50, we can detect over 80% of dropouts with the logistic regression model. So then moving forward, I tried to interpret both the logistic regression and the spline-based model. Here we find that downtown east side is now showing up near the bottom as not being that important, which was surprising. And at the top, we have grades and income assistance or poverty, history of living in foster care, mood or anxiety disorders, and unstable housing. Also, if somebody is a teenage parent. Now, I was a little surprised that opioid or drug use didn't show up in the top, but then if we look at kind of the odds ratios, we see that some factors like history of psychosis or hospitalization related psychosis have really large confidence intervals. So those effects are just not that consistent. So it's not that those things don't matter, it's just that they're hard to use for prediction. And to summarize, logistic regression was hard to beat. It's pretty good for this type of data. We found that we can predict, who's going to drop out with about 80% accuracy. And key predictors were academic performance, income assistance, poverty, and foster care history. Of course, there are some limitations. We can't really examine homelessness because we didn't have shelter data. The complete case analysis has kind of shifted a little bit more recent until 2006 to 2009. The MCFD data doesn't go back quite as far. And these are all information, all the data sources we use. There's a lot more on this in the PDF report that you can download from the event page, which I encourage you to check out. And feel free to ask me any questions. Ooh, that went by fast.
Thank you, Dr. Hutton. So yeah, if anyone has any questions for Dr. Hutton, please feel free to ask them in the Whova chat. And definitely check out the document that was uploaded on the Whova file.
Yeah, it goes into everything in a lot more detail than I was able to cover here, which will help provide some context.
Absolutely. So if there's any questions, please feel free to ask them. So I have a question for you, Dr. Hutton, from Marisha. She asks, which predictor surprised you the most?
Well, actually, I think I was surprised most that opioid related physician visits didn't show up as like one of the top things. And it could be that our sample is, in this case, is younger, that those individuals haven't had a chance to become involved in using opiates. Whereas I anticipate that would become much more important after high school. So we're kind of following up now in examining what happened to the same individuals kind of in their early adult years up until about 29 or so. So that I think that'll show up as more important. But yeah, I was really surprised that that came out as not being as important as I expected.
Thank you, Dr. Hutton. We have another question from Carrie, who asks,
Sure.
I'll be interested in following up with you regarding the impact of secondary education for individuals who may come into our care in corrections. She's asking, how can she connect with you?
She can feel free to email me. I can just put that in the Zoom chat.
Wonderful.
Feel free to share it on whoever, wherever. Yeah.
Sure, I'll share it right away. Thank you, Carrie. I just shared Dr. Hutton's email as a question. I can also put it in the chat.
I should also mention that there's like a separate project we're doing at the BC CDC on the provincial overdose cohort. And so we're examining involvement with corrections in that project. But the focus again, due to the nature of the data, is on older individuals. So we don't have any data on youth in that project, unfortunately, which is a limitation. But we are getting some insight into how incarceration impacts overdose risk, for example. That we can talk about another time.
Awesome. And we have a question from Jennifer, who asks, when looking at mental health, did they look at PTSD or how trauma may be connected?
I wanted to look at that in more detail. There's just so much that we can examine in one analysis. I mean, you can think of a child who has ended up in foster care as likely having experienced some trauma, certainly in terms of family separation trauma. So we found that was incredibly impactful, and one of the things that stands out as interfering or reducing the likelihood that a kid will graduate on time. And I would expect that other forms of trauma would have similar impacts. So we looked at mood or anxiety related conditions, and stress related disorders like PTSD would have been lumped into there. So when you see mood or anxiety as a factor that's showing up, it includes other variables or other conditions. So I think, yes, it would be very important, but we didn't look at PTSD specifically. Something that could be examined in the future, absolutely.
And we have time for one more question if someone wants to ask away. All right, so it seems like that's all the questions. We have about a few seconds to spare. So I think that we can just move on to the next lightning talk. Thank you so much, Dr. Hutton, for your super insightful talk. As someone who grew up in this city and graduated from high school not that long ago, I found that really particularly impactful. So thank you very much.
You're welcome. Thank you too.
Wonderful. So on to our next talk. I'd like to present Hannah Kleppo, who is a master's student studying experimental medicine at the University of British Columbia. She's also a research assistant at the BC Centre of Substance Use. The title of her talk is Demographic and Sociocultural Factors Associated with Non-Fatal Overdose Among Patients Enrolled in the Optima Trial. So Hannah, the floor is yours.
Thank you so much, Raha. So like she mentioned, my name is Hannah and I'm a master's student at the University of British Columbia. And today I'm going to be talking to you a bit about my thesis project, which involves the characterization of overdose survivors enrolled in the Optima trial. So our story starts with the overdose crisis, which I'm sure many of you know have taken the lives of so many Canadians. Since 2016, the number of deaths attributed to opioid use has grown drastically and it's predicted to increase in the upcoming months. While all provinces are affected by this crisis, the Western provinces, including BC, have had the highest rate of illicit opioid toxicity deaths in 2021. And while there are many reasons for this, the contamination of the illicit drug supply with fentanyl is one of the main factors. And fentanyl analogs are synthetic opioids, and in recent years have been involved in many accidental overdose deaths. So in 2021, toxicology reports found that they were involved in 87% of deaths. And while fentanyl is a huge risk factor for both fatal and non-fatal overdose, many studies have also looked at other factors that might be associated with an increased risk of overdose, including socioeconomic, social, and individual factors. However, many of these factors have focused on individuals who use heroin or inject drugs, and few studies have looked at individuals who use prescription opioids and fentanyl analogs. And this is a huge knowledge gap considering how the illicit drug market is changing and more people are seeking prescription opioids. So the objective of our study was to determine correlates of non-fatal overdose among treatment-seeking individuals with prescription-type opioid use disorder. And knowledge of these correlates can be used to inform interventions and mitigate overdose. So to get into some of the logistics, we drew data from the Optima trial, which is a randomized trial studying the effectiveness of methadone and buprenorphine for the treatment of prescription-type opioid use disorder. This trial was multi-centered and took place in 4 Canadian provinces. It was also open label, meaning both patient and clinician knew which treatment the patient was receiving, as well as pragmatic, so meaning that the treatment was administered as it would be at a regular addiction clinic. And a variety of questionnaires were administered prior to treatment initiation, including one about a history of non-fatal overdose. So our study sample in particular included all participants with a valid response to this questionnaire, which was a total of 271 participants. To look at factors associated with non-fatal overdose, we used data from screening and baseline questionnaires, which included information on demographics, education, living situation, concurrent mental health disorders, substance use, etc. And for the current study, we focused on factors that had been previously shown to be associated with non-fatal overdose, which fell into 3 broad categories. So all sociodemographic and mental health variables were self-reported, and then substance use was analyzed using urine analysis. And to determine if there was any association between the chosen variables and the outcome, we first used unadjusted logistic regression, and then we built a multivariable model to determine the adjusted odds ratios. And what we found was that there was a high prevalence of non-fatal overdose within our sample, with 58 responding yes to having a history. 32% reported having a non-fatal overdose in the last 6 months, and most people reported using opioids at the time of last overdose. And after adjusted analysis, we found that the odds ratios that were statistically significant with non-fatal overdose were having received income assistance in the last month, being homeless, as well as having a positive urine drug screen for fentanyl and methamphetamine. So what does this mean? We can use these factors to identify individuals at high risk of subsequent overdose and provide them with more well-rounded care. It also provides support for drug checking, safer supply of opioids, as well as supportive housing initiatives. I think my slides are freezing a little bit here. So the next one just talks about a little bit of some of the limitations. So our data was cross-sectional, so we can determine any temporal relationships between the variables. There was a limited sample size, of course, which is part of our future directions, is to look at other factors that we missed during this analysis. So things like route of transmission, access to healthcare, as well as looking at recent non-fatal overdose. And regarding the theme of this conference, I'm no expert in virtual substance use care, but I think it does have the potential to improve treatment for overdose survivors. So specifically continuing care programs for post-treatment, as well as counseling for mental health disorders. So thank you so much for listening to my talk, and I'd be more than happy to take any questions that you may have.
Awesome. Thank you so much, Hannah. So I believe we. Okay, if there's a question from anyone in the audience, please feel free to ask away on Huva. Awesome. So we have a question from Marisha who asks, what are the next steps for the Optima trial?
So the Optima trial is now completed. So it was finished in 2020. So the main outcome for the study was looking at whether these treatments affected opioid use in the patient. So this study was a little bit of an ancillary study. So in terms of that, there's multiple studies going on with the data with Optima, and this is just one of them. So yeah, there's there'll be more information on like retention and treatment as well, which was one of the main outcomes. And I think there should be publications coming out soon. So I think that's probably next steps for right now.
Awesome, thanks, Hannah. Also, we have a request from someone in the Zoom chat. Amanda asks, she says, hi there, I really enjoyed your presentation. Would you be able to post the slides, please?
Yeah, of course. Do you want me to post them in the Huva or?
Yeah, there's a Huva chat. And if you feel comfortable posting them there, that would be a great place.
Yeah, absolutely. I also have like references. I didn't include them in the presentation, but if people are curious, I can definitely post those as well.
Absolutely. Are there any other questions for Hannah? Hannah, I have a question for you.
Yeah.
Was there anything that really surprised you while conducting this project?
Like anything at all, or?
Yeah, was there, maybe something, you have a little anecdote of something that you maybe did not expect going into it that you found interesting?
Yeah, for sure. I think just the amount of work that goes into an analysis like this, I didn't really realize how much like background and statistics is so important for this type of work. But also just, I think the amount of people who were positive for fentanyl when they came in starting the study, I didn't realize like how many people actually use fentanyl on a regular basis. I think that was something that I was very shocked to see, and as well as like using both fentanyl and methamphetamine concurrently. So I thought that was very interesting. And I know that there's like a study coming up that's going to be looking at methamphetamine use as well, which is run by like the same people. So it'll be interesting to see what those findings are.
Awesome, thanks. And there's actually 2 more questions from the Q&A on Zoom. Sorry, I missed these earlier. But Jennifer asks, what are the mental health concerns that were noted as part of the factors?
Yeah, so initially we were looking at anxiety and depression because those were the only 2 that were looked at within the trial. And then we found that they were highly correlated. So we just ended up using or adding depression into the final model just based on previous research. We found that depression was more highly associated with non-fatal overdose in other studies. So that's what we used for ours as well.
Awesome, thanks, Hannah. And there's one more. Someone asks, I think that I missed the outcome, or is this ongoing? I think the outcome, it isn't ongoing, but they ask, which arm did better out of Suboxone or methadone?
I think I'm allowed to say this. I'm not really sure, but they both actually were they were pretty equal on both ends. And retention was actually quite low in the trial, which is unfortunate. But there was also problems with COVID, unfortunately. They had to stop the trial prematurely. So that might have been why as well. I'm not too sure, but yeah.
Wonderful. And one final question from Kelly is, how do you think this knowledge will impact practice?
I think that's a really great question and something that I'm not sure of quite yet, but I think in the future, these factors can be used to identify people who are like especially at high risk for future overdose, because studies have shown that people who have overdosed are more likely to overdose in the future. So knowing these factors exist and kind of maybe doing a more like multifaceted approach to treatment, hopefully we'll get there one day. But yeah, I think maybe that would be something, just using them as like a risk factor marker in people with overdose.
Awesome. Thank you so much, Hannah. And that was all the time we had for Q&A for Hannah's presentation. So our next speakers are Sheila Avis and Rob Johannes, and they're affiliated with the social service charitable organization Fred Victor. The title of their talk is Equity-Oriented Best Practice Guideline for Virtual Support Groups, Lessons Learned from a Low Barrier Health Promotions Team. So Rob and Sheila, whenever you guys are ready.
Good day, everyone. I'm Rob with 2 Bs. I come to you as a Vancouverite residing in the unceded territory of Toronto to discuss an in-progress best practice guide for remote service delivery. And it is also my birthday today, so you may notice a little cake in our slides. This guide is developing under the umbrella of Fred Victor, which is where our health promotions program provides low barrier peer support groups, both for downtown Toronto as well as for Scarborough. Where many services in Vancouver are concentrated in the red circle denoting the downtown east side, Toronto has pockets of communities spread out over an area 5 times the size of Vancouver, sparking different kinds of service coordination and isolation, which can be a contributor to substance use. We're finally recognizing that the opposite of addiction is in fact human connection. The warm, fuzzy feelings you get in friendly company are the same centers of the brain that are triggered by substances such as heroin and cocaine. COVID is not an isolated occurrence. Natural disasters, wars, pandemics, all disrupt systems and amplify existing inequities. We always needed to create an anti-oppressive space on virtual platforms. COVID just provided the opportunity for us to do so. In early 2020, when we started this, nobody had protocols for virtual programming. Even hospitals were using Zoom or WebEx without concrete privacy and confidentiality policies, for example. We can't assume that our definition of equity is universal. Without clear statements of terms, protocols can become co-opted, appropriated, turned back, and weaponized against our communities. So the bedrock of this guide came from partner organizations, legal colleagues, asking program participants what would facilitate their engagement in virtual forums, accessing international practice, as well as our own research. One of the most successful avenues was consulting the St. Jamestown Service Providers Network, which is a 45+ agency collaboration in Canada's most densely populated, ethnically diverse, and often overlooked neighborhoods. Quick and dirty snapshot of the primary contents of a guide like this. We'd have objectives and definitions, implementation, practical guidelines, proactive evaluation. So how do we ensure that the guide stays relevant and reflective, and helpful resources? So I'm going to pass you on to Sheila, who has been working remotely in translating this document into practice from the Musqueam, Squamish, and Tsleil-Waututh territory, known as Vancouver. Sheila, take it away.
Thank you so much, Rob. So our team has been putting this guide to practice at 2 weekly support groups, which had to shift to remote delivery because of the pandemic. One group is virtual with video and the other is dial-in only. As one of the group facilitators, I saw that all of the group members come from communities impacted by poverty, drug poisoning crisis, and interlocking oppressions like racism, ageism, and ableism. So 3 critical reflections from my experience putting the guide to practice. As a facilitator, I saw strength in connections and a sense of community, the impacts of systemic barriers, and my own gaps of understanding. So we felt a sense of connection and community during a time of great isolation, best exemplified by how we cheered on and celebrated one of the members' new hobby of learning how to draw. And this is one of her beautiful drawings and my personal favorite. But we also saw how barriers like the digital divide were still an issue. Not everyone has access to the internet, tech devices, or digital literacy. This is also why we offer a dial-in only support group. And because I benefit from systemic oppression like ableism and ageism, I come with many gaps of understanding, and that's why it's key to center members' voices by asking what has worked and what needs to change. This is also why it's important to have regular audit of the policy, practice, and processes of your virtual programming, also called equity audit, using feedback from members and many resources on equity-oriented best practice. So to close, we'd like to share the compilation of resources on equity-oriented best practice for virtual programs, and also asked for your input on other resources we might have missed. The link is on the screen there, and we'll share it again on the next screen. Again, the link to the resource and to give your input is tinyurl.com/fvresource. Thank you, everyone, for listening, and we look forward to connecting with you, and happy birthday to you again, Rob.
Wonderful. Thank you so much, Rob and Sheila, and happy birthday indeed, Rob. Thanks for being here with us.
Thanks.
So now we have 5 minutes.
I wasn't just saying that to milk good favors from the audience.
Awesome. So now we have 5 minutes of Q&A from the audience. And I'd just like to kindly ask that if you do have a question, please ask it in the Whova Q&A tab, just so it's easier to keep track.
Thanks for saying Whova as well. All this time I was thinking it was a Wova. I don't know why.
Same here, yeah. I thought it was Wova.
Awesome.
We'd really appreciate your input on any practices that you may be engaged in currently on building remote delivery platforms. So we've shared the link in the chat there.
Yeah, everyone, please feel free to engage with the link that Rob posted. I think I can also post in the Whova group chat. I'll do that right away. And we also have a question. So the question is, how is the guideline going to be expanded to service providers? And that's from Amelia.
That's a really great question. We consulted with a lot of other service providers on this. So this is kind of a living document. That's really what we would like it to be. For example, the Sick Kids Center for Community Mental Health had already sketched out somewhat of a policy that we adapted parts of that. There's a lot of different collaborative tables across Toronto, for example, the Downtown East cluster and others, whereupon leadership attend those meetings, and that's where this guide would be put forth, ideally for something that can be adopted sector-wide. But given that catchment areas don't mean as much these days in the pandemic, we've really opened our scope of where we can practice. We're hoping that this can become more of a standardized, not necessarily standardized, but something that can be taken into consideration, for example, through using platforms such as this, as well as other colleagues that we have in Vancouver. I still have a lot of folks out there as well. So yeah, I hope that answers the question. I don't know, Sheila, if you had anything to add to that.
No, I think you summed it up, Rob. Thanks. And thank you for the question.
Wonderful. We have another question from Marisha, and she asks, how can these guidelines inform future virtual support groups?
Well, the thing is, as I'd mentioned before, when we started doing this, it was a very uncharted water. And I was quite surprised by that. So many other agencies had not, developed best practice guidelines. You host a group in person, everyone's sitting there in a circle, you go through a comfort agreement right away, and what are the guidelines for the group and what's going to allow this to be an inviting space. But online, we often just go right into it and start doing the content without actually taking a step back and going, maybe we need to look at what safety looks like in this space. Sheila's had instances where someone had to leave the group, or all of a sudden they disconnected. We need to make sure that we've got people's phone numbers, that we can call them, and check in and make sure everything's okay. And some people will give us suggestions. Say, if I drop off, I'm prone to seizures. Just call me to check in. And here's the secondary number if I am having a seizure that you can call. So I think the idea of creating an actual anti-oppressive, accessible environment, we always needed to do it on the internet. We just never really took the time to consciously carve it out. So I hope that the pandemic has provided us a space to really do that.
And just to quickly add to what Rob is saying, I think that's also why doing that regular equity audit is so key, right? And I think two questions for all folks here who run virtual programming or virtual groups is to ask, is this working for my community member or for the community that I'm serving? And also who is excluded by this particular format that we're having? So for example, if your groups are only happening through Zoom virtually, and a lot of the community members that you serve don't actually have computers or access to the internet, then perhaps consider moving to a different format, like a call-in only program. And again, those are the questions that can come out from your equity audit processes. So I hope that answers the question, and thank you for that, Marisha.
Wonderful. Thank you so much, Rob and Sheila. So unfortunately, time is up for the Q&A period for this presentation. There is a question lingering in the Q&A chat that maybe you guys can address in a private conversation with Hazel. Also, another individual says in the chat, they can't see the link. Do they need to sign into tinyurl? Maybe you guys can address that in the chat as well. Wonderful. So we are on to our final speaker for the lightning talk session. And we have Prashanth, who's a student here at the University of British Columbia. And his talk is titled Implementing Computational Neuroscience and Mathematical Models in Reinforcement Systems to Optimize Abstinence in SUD Patients.
Sorry, that was a pretty long title. So my name is Prashanth. I am a first-year student at UBC, and my research focuses on implementing computational neuroscience in reinforcement systems to optimize abstinence in SUD patients. So before I do go on, I just want to acknowledge my supervisor, Dr. David Ruttler. He's a genius, and he's assistant professor at the University of Toronto. Currently works at Ontario Shore Centre for Mental Health Sciences, and yeah, he's the brains behind this whole operation. So what is substance use disorder? Substance use disorder, SUD, is a broad term that refers to problematic drug and/or alcohol use, and it includes individuals who have a substance use disorder or those in remission from the disorder. Opioid use disorder, alcohol use disorder, and stimulant use disorder are the three most common types of SUD. If you do look at the figure on the right, you'll see just how large scale this problem is, and we seriously need a resolution for this because millions of people die. The reward system is the portion of the brain that produces feelings of pleasure when an action leads to a positive outcome, and it's responsible for motivation and reward-driven learning. So again, the figure on the right will show you what specifically is responsible for this reinforcement. Our research will contribute to a more effective treatment option for individuals with SUD, and the discovery of the brain's reward system will allow us to guide behavior through reinforcement learning, which can be done using technology. We theorize that reinforcement can promote abstinence, but we must first evaluate how well computational models of the brain's reward systems control behavior. And we will use computer simulations to support our theory that addiction is a learned response. So as I mentioned, we will use a computational model of the basal ganglia to predict patterns of neural activity in response to different reinforcement events. And we're using this specific part of the brain because it's responsible for reinforcement, so it's going to give us precise results. The model will be tested using a computer game that stimulates a simplified version of a real-world reinforcement task, and we'll create a computer simulation that replicates decisions made by people playing a modified version of the game. And this game will be comprised of 12 different tasks. In each task, the computer will decide how to distribute reinforcement between two options. So essentially, we're providing it two options, and it's going to be deciding which one do I take, what path do I take. The comparison will give us insight into how well different models can capture human behavior, and the model's performance will be tested using data from virtual humans' decisions during 12 experimental sessions. To verify that our research advances the state of the art, we will compare the performance of our model to that of other models, and we'll test whether a computational model can account for a significant amount of variance in experimental data, because it's heavily dependent on how we build this computer model to get results. The reinforcement learning technique has been proven to be successful in the treatment of addiction through the implementation of contingency management, but it will be improved through the use of technology. And the key thing is improved. So we're going to be using cell phones and other devices to do so. And if you look at the paper on the right, this is a research paper that found contingency management works best in conjunction with treatment services and support rather than a standalone method. And so what we hope to do is propose a standalone method. Although behavioral treatments such as cognitive behavioral therapy and contingency management ameliorate SUD symptoms, these approaches often fail to provide a complete and sustainable recovery for SUD patients. And the paper on the right is Higgins 2006. What Higgins 2006 failed to mention, however, is that while CBT uses cognitive techniques to treat addiction, it does not include reinforcement learning, which would otherwise teach abstinence by providing positive reinforcement. And our research will provide more information about how the brain makes reinforcement learning decisions, ultimately enhancing the design of reinforcement technologies. So, I mean, we could reach out to companies like Fitbit and Apple with the Apple Watch that would help us. We currently plan to start our research at Ontario Shores Centre for Mental Health this May and then conclude it in August. And we aim to determine which reinforcement schedules are optimal in promoting abstinence via self-reporting. And we also want to determine which reinforcement schedules are optimal in promoting abstinence with the use of a mobile phone's various sensors. And we're going to continue this research in progress. We want to determine whether or not abstinence is maintained when contingent reinforcement is discontinued. And lastly, we want to analyze and interpret the results which we have obtained from our research and form conclusions which we can then send to companies like Fitbit and Apple, which can use it integrated in their devices.
Awesome. Thank you so much, Prashanth. That was an incredible talk and it was very speedy. So now we have a few minutes of Q&A period. And if anyone has a question, please ask so in the Whova chat.
That went by really fast. Wow.
Yeah. So we have a comment and question from Risha in the audience. She says, great presentation. Your work seems to focus on abstinence. Could this work be transferred to a program for people who do not plan on using an abstinent focused approach?
Yeah, well, the use of computational neuroscience and understanding reinforcement systems, it's a very new thing. Even the field of computational neuroscience is still in its infancy. So it could potentially, that's not what we're focused on, but yeah, that's something we're going to consider in the future.
Awesome, thank you. We have another question from an audience member. Heather asks, can you give us an example of what reinforcement learning looks like?
Yeah, for sure. So we use unsupervised machine learning and neural networks neural networks is like artificial neurons in a computer, and unsupervised machine learning is when we don't tell the machine to do anything, we don't input an algorithm, but the machine will learn on its own through many trials. So for example, in the game, if we provided two options like cigarette, not a cigarette, to identify or to help reinforcement systems with people who use nicotine, the first time it may fail or it may use a specific option, and we'll see activity in the neurons. And then the next time we're going to try to feed it information to make it choose another one, and we're going to see how it's reinforced in that sense. And then we can apply that to humans.
Awesome, thank you. Are there any other questions for Prashanth? There is one in the Zoom chat. So Jennifer asks, with SUDs and treatment being so complex, I'm wondering how this will be effective. The idea seems somewhat simplified. Do you have anything to add to that comment?
Yeah, well, this was a 5-minute talk, so I didn't get to go too much into it, but sorry, what was the original comment addressing?
It talks about how SUDs and treatment are really complex, and they're wondering if this will be effective.
It can be effective, yeah. This is something looking maybe years into the future, but we could use, for example, brain-machine interfaces to kind of promote this and have it distributed on a larger scale. But yeah, currently we're just looking into companies like Fitbit and Apple. They use the Apple Watch, which would help with reinforcement. But yeah, that's a very valid concern, and we are going to be looking into that next year, though.
Wonderful. Thank you so much. Given that the lightning talk session is now coming to an end, it is 12:15. I unfortunately have to end our Q&A period a little bit early. I just want to give you guys a quick closing remark and just give a big thank you to all of the speakers today. This is just a reminder to vote for your favorite talk from this session. The voting polls can be found on the Whova tab on the right hand of the screen. You can also view the e-poster gallery on the ECD website and our video gallery, and vote for your favorite poster and video as well. And the winners for all of those will be announced before closing remarks. Next up, we have, let's see what we have next. Next, we have e-poster and video viewing from 12:15 to 12:45. So if you would like to make your way there, that would be awesome. And let me know if you have any questions. I will stick around for a few minutes. Thank you so much, everyone.